Hemolysis can be very challenging for people, but we're going to make it super easy for you, and you're going to get the answer to every question on all these hemolytic anemias. That's because all forms of hemolysis have an awful lot in common. There's a lot more in common than people think. They all cause a sudden decrease in hematocrit. They all cause an increase in LDH. LDH comes out of cells. You destroy cells of any kind, the cells release LDH. So anything that breaks down cells, whether it's heart or brain or muscle or red cells, cause a high LDH. That means a high LDH is irrelevant. A normal LDH really helps exclude hemolysis. You get an increased indirect bilirubin because newly released hemoglobin needs time to be recycled. And reticulocytes will go up. Now, it may need a couple days for the reticulocytes to go up, but they will go up in a day or two or three. And they all can decrease the haptoglobin. They all can. Even the extravascular ones, even the ones that are happening inside the spleen, can decrease the haptoglobin. Haptoglobin is a plasma protein that takes newly released hemoglobin and brings it around and recycles it in the system. Haptoglobin is like yellow taxi cabs that pick up all the people outside the theater on Broadway here, and they recycle them around to their homes and hotels. But it gets used up. Now, there's a slight increase in MCV, and that's because reticulocytes are slightly larger. If every cell in the body was a reticulocyte, the MCV would be about 120. However, since we're talking about just 10 or 20% reticulocytes, a reticulocytosis alone just brings up the MCV 5 or 6 points. Hyperkalemia can happen if it's really massive, because 95% of the potassium in the body is intracellular. Chronic hemolysis with chronic indirect bilirubin increase with chronic saturation of indirect bilirubin can cause bilirubin gallstones. You should expect to see that in sickle cell. Chronic hemolysis, you should expect to see that in spherocytosis. Sickle cell disease is extremely common. It is a chronic, well-compensated hemolytic anemia. As a medical student, it won't seem that way to you, but that's because you're seeing the 1% of people who are the most ill. You're seeing the person with sickle cell who's admitted, but there are many people living with sickle cell at home who are just fine. The reticulocyte count is always high. That's very important that you understand that a low reticulocyte count in sickle cell is extremely dangerous. You should look for a disease like parvovirus, because a person who has sickle cell disease should be living at a reticulocyte count of 5, 10, 15, 20. It should be 5 to 20 times higher. Painful acute vaso-occlusive crises can happen just any time. They can. They don't have to have a reason, but they're definitely increased by hypoxia. That's the whole fundamental illness. You see, sickle hemoglobin functions pretty normally at a normal oxygen level, but when they become hypoxic, they definitely sickle. Now remember, a sickle crisis is not a hemolytic crisis. It doesn't mean that all the cells are disappearing. It means they change in shape. Hypoxia changes that shape. Dehydration changes that shape. Infection, cold temperatures. Sickle cell is caused by one single point mutation at position 6 of the beta-globin chain. Valine replaces glutamic acid. This is one of the few mechanism questions asked on step 2. Just because it's step 2 doesn't mean you don't get a handful of mechanism questions, and this is one of them. So before I get a blood smear and electrophoresis, how will I suspect it or answer the most likely diagnosis of sickle cell? The answer is you're going to look for an African-American person with a sudden onset of pain in the back, the chest, the thighs, the back, the chest, the thighs, and they may have a fever. Now, we don't know why it's pain in the thighs. It's just not clear, but we do know that that's the presentation. They may have fever, and that fever is extremely important, because if you have fever with sickle cell, you don't wait to give the antibiotics for the cultures. You got to give those antibiotics right away. They're going to die of sepsis. Jump on it. You can save somebody's life today. Now, it is rare for an adult to present with acute crisis without a clear history of sickle cell. That's being generous, actually. The short answer is it's almost impossible for you to get to adulthood without a history of clearly having sickle cell disease. Let's look at the complications of sickle cell, and you have to know these all the way. Bilirubin gallstones from high, chronic, indirect bilirubin levels. You get an increased infection because you got no spleen. If you got no spleen, you get encapsulated organisms. This is extraordinarily important because let's say you're on your medicine rotation now and you're using this modality for your shelf exam, as you should. And just as you go back to the floor, because you sneak off into your call room to listen to this on your laptop or something, and you find that the person's got 101 fever or 102 fever, and your resident you're attending missed it. You got to stop what you're doing right now and page or call your resident and say, hey, listen, the sickle patient has 101 fever. We need to give antibiotics right now. They get osteomyelitis. And although Staph aureus happens, the answer is still salmonella. Yes, salmonella, because that's the published figure. That's it. Now, you don't have to agree with everything I say, but when it comes to your test on test day, just answer what I say. Even though you don't agree with it, it's still the answer. It's salmonella is the most common. Retinopathy happens because the sickle cells infarct the eyes. You get visual disturbance. The sickle cells actually infarct the eyes. They infarct the brain. That's why outside developed countries or in places where you don't have access to transfusion, all these little kids stroke out at the age of 5. Man, it's terrible because it infarcts the brain, infarcts the eye, and infarcts the bone. You get an enlarged heart, hyperdynamic features from the chronic anemia. You get a systolic murmur. Skin ulcers, this is particularly of the lower extremities happen. We're not clear why, but you do get them. And avascular necrosis of the femoral head happens because the sickle cells infarct that bone. Now this one's special. This is a point that changes the person from the 230 to the 260, from the 240 to the 270. Children with dactylitis. Children will present with dactylitis. Inflammation of the fingers. Not clear why, but you get it. The best initial test for that sickle cell disease is the peripheral smear. Look at those sickled cells. Look at those sickled cells. One of our own patients at Jamaica Hospital. And my very own chief resident there, here, because this is our own patient showing you, that's it. And they'll show you that smear. They'll show you that smear and say, that's it. Now, can a sickle cell smear, can that tell you the difference between the heterozygote and the homozygote? Can I tell you whether it's a trait or sickle cell disease for the smear? The answer is yes, you can. Interestingly, if you thought no, that's very common as a wrong answer. See, sickle cell disease gives sickled cells. But trait, the heterozygote, is hematologically normal. You don't have sickle cells in trait. Period. That's it. The most accurate test is a hemoglobin electrophoresis. Because trait will not give sickled cells, you have to do the electrophoresis to see if somebody's got a trait. Now those features on the previous slide of knowing that there's bilirubin gallstones and osteomyelitis and you can have a stroke and visual disturbance, you must know them to the marrow of your own bones. What's there? It's not going to change. Which of the following is found on a smear in the patient with sickle cell disease, the homozygote? The answer is Howell Jolly bodies. Howell Jolly bodies are a sign of autosplenectomized patients. If you got no spleen, you have Howell Jolly bodies in the red cells. Basophilic stippling is an unusual thing from little dots across the red cells with lead poisoning. Bite cells are when the Heinz bodies get bitten out by the spleen. That's a test you can do today in G6PD, glucose 6-phosphate dehydrogenase deficiency. These Heinz bodies get bitten out, removed. The schistocytes are fragmented cells that seen with intravascular hemolysis, such as DIC, TTP, HUS, and morula are seen inside neutrophils with Ehrlichia. Nucleated red cells are found with premature release of cells. It's like little child soldiers. It's the step just before reticulocytes is nucleated red cells. The initial therapy of sickle cell disease hasn't changed in many years. It is oxygen, hydration, and analgesia. Analgesia, of course, because the person's in tremendous discomfort. Oxygen is indispensable to reversing the cause of the sickle crisis because sickle hemoglobin is normal at normal oxygen levels. A fever or a white count higher than usual makes antibiotics indispensable. Ceftriaxone, levofloxacin, moxifloxacin. If it looks like the treatment for community-acquired pneumonia, that's because it is, because it's many of the same organisms. I cannot overestimate this because this is where people are going to get their lives saved. Folic acid is in everyone because there's a chronic hemolysis. People are producing cells all the time, and they use up their folic acid. And cell production becomes like driving your car. In other words, the cells will continue to be made and made and made, and the folic acid used and used and used until, bing, it just runs out and the car stops. So it's kind of like saying, well, the car was running until it stopped. And that's what happens with folic acid deficiency. It will continue to make cells until you just run out. So everybody's got to be on folic acid. Because they're autosplenectomized, you should get a pneumococcal vaccine from childhood, as a matter of fact. And you should get one revaccination 5 years after the disease is found. Hydroxyurea prevents recurrences by increasing hemoglobin F. Now, it doesn't increase hemoglobin F by like 40%, but just an extra 2 or 3 or 4% of fetal hemoglobin is enough to decrease the recurrences of crises. You use hydroxyurea if people have 3 or 4 crises a year or more. You don't use it on someone who has 1 crisis a year because, 1, it's hard to demonstrate a benefit. 2, in long-term use, hydroxyurea is associated with a risk of secondary malignancy. So you don't wait for the results of testing when you have a fever. You must start antibiotics. No spleen means overwhelming infection, means death. Save someone's life today. You're going to do it. We love in Step 2 High Yield to work backwards from the answers because there's less of them. There are many questions on your Step 2 test, but very few times where the answer is exchange transfusion. So work backwards some answers in all of your studying. It'll make it easier for you. Exchange transfusion is the answer when you have a severe vaso-occlusive crisis with acute chest syndrome, you're infarcting the lungs, priapism, stroke, or visual disturbance from retinal infarction. Because these are the circumstances in which you've got to correct it instantaneously. Exchange transfusion or transfuse, get that percentage of sickle hemoglobin down. A patient with sickle cell crisis is admitted. 43-year-old man with sickle cell disease admitted with a pain crisis. His only medication is folic acid. He is taking folic acid. His hematocrit goes from 34% and on the third hospital day drops to 22%. What is it? What's the test? This is parvovirus. But parvovirus, the first thing you do to see whether it's freezing that marrow, is the reticulocyte count. Remember, the peripheral smear can't gauge the severity of hemolysis, and the peripheral smear doesn't help us here. We know the guy's got sickle cell disease. If he's on folic acid, there's no point doing a folic acid level right now. You see, folic acid causes aplastic crisis, which freezes the growth of the marrow, but he's on folic acid. Parvovirus suddenly freezes the marrow in people with hemoglobinopathies. And by the way, there's only parvovirus B19. There's no B1 through 19. There's no B12, for instance. There's no parvovirus A19, just B19. And it infects the marrow and freezes it and stops it. And what's the first cell that goes? The reticulocyte count. People with sickle cell disease should have 10 and 20% reticulocytes, and now it goes down to 1 or 2%. Now, these reticulocyte count should be done first, not the IgM level, because the IgM level takes time. Now, overall, the most accurate test for parvovirus is the PCR for DNA. But you're not going to do that first, because the PCR for DNA is the most accurate, because the actual organism. If the question should ask you the therapy, intravenous immunoglobulins is the best initial therapy. Bone marrow will show giant pronormoblasts, but it isn't better than a reticulocyte count at measuring the severity of hemolysis. We rarely do the bone marrow for parvovirus. To summarize the answers for parvovirus, it's a sudden drop in hematocrit in a person with a hemoglobinopathy, particularly sickle cell disease. The reticulocyte count drops first. That's your first answer. If those retics are down in sickle cell crisis, it either means folic acid deficiency or parvovirus. And since this person's on folic acid, you should be looking for the parvovirus. Sickle cell trait is a patient who's heterozygous for the sickle cell gene, AS. The only manifestation is that they can't concentrate their urine. That's called iso, meaning same, stenos, urine, same strength urine as the blood. This may seem like a small issue, but if you have a person who's admitted with diabetic ketoacidosis or hypernatremia or non-ketotic coma, it's a big deal. It means you're not able to concentrate that urine. Now remember, patients with trait are hematologically normal. They have normal CBCs, normal smears. And just because they have a little hematuria in the urine does not mean that they have any hematologic manifestations, and there's no treat for sickle cell trait. There's no treatment for trait. Hereditary spherocytosis is a genetic defect in the cytoskeleton of red cells. You see, red cells have a biconcave disc. That's not exactly a natural shape. There's no natural shape in the world. There's a biconcave disc hollow in the center. It has to be forced into it. It needs a skeleton, ankyrin, and spectrin. Force it into that shape. So if you don't have that cytoskeleton, it leads to an abnormal shape, which is round. So that means you also lose the flexibility. See, red cells have a tremendous flexibility to get around corners, go through the spleen, go around narrow vessels, squish themselves through capillaries. But if you have spherocytosis, if you've lost the cytoskeleton, if you have an abnormal round shape, you lose the normal flexibility characteristic of biconcave discs that allows red cells to bend in places like the spleen or the blood vessels. And the problem with this is they get crunched in the spleen. What is the answer to the most likely diagnosis question, spherocytosis? You can look for recurrent episodes of hemolysis in a young child or a newborn. The patient has intermittent jaundice. They have a big spleen because that's where the cells are getting crunched up. And there's a family history, usually, of hemolysis and anemia and bilirubin gallstones because there's a chronic hemolysis leading to chronically elevated levels of bilirubin. So this is not going to be a one-time deal, and also because it goes on for a long time, the spleen has time to enlarge. When you have a single episode of hemolysis, let's say autoimmune hemolysis from penicillin, you don't have time for that spleen to get big. But it does get big when you have spherocytosis, and there's time for it to enlarge. The cell size is a little small in spherocytosis, a slight microcytosis. This is because the abnormal cytoskeleton makes the cells lose volume. They actually lose a little liquid. They become a little dry in a way. That's why the cell size goes down. Now, MCV is a volume. It's not just a shape. In other words, if it was a totally normal volume and you just squished it into a ball, it wouldn't be a low MCV. The MCV measures the total volume of the cell. It's because there's an increased mean corpuscular hemoglobin concentration. And I must tell you, this is an indispensably important feature because this one feature alone will allow you to answer what is the most likely diagnosis. Each red cell has more hemoglobin than it's meant to have. So there's an increased MCHC. The Coombs test negative tells you, hey, we don't have autoimmune hemolysis. And the other reason this is important is because most people don't know that autoimmune hemolysis also gives spherocytes. Did you know that? Because the antibodies grab a piece out of the red cell membrane and make the cells a little small and spherocytic. The most accurate test is osmotic fragility. This means that when you place cells in a hypotonic solution, they burst. Normal cells that are placed in a slightly hypotonic solution should be able to swell a little bit, but these don't. They go pop. Spherocytosis simply needs chronic folic acid replacement because it supports the red cell production. If people have really bad disease, you need to remove the spleen. The spleen is the site of where the red cells are destroyed. You don't get rid of the spherocytes, but splenectomy stops the hemolysis. Even if it doesn't eliminate the spherocytes, it does stop the destruction. Autoimmune hemolysis can also be known as warm or IgG hemolysis. Although we see it from penicillin and sulfa drugs, allopurinol, phenytoin, and rifampin, half the cases are unknown. See, clear causes are things like CLL. Those lymphocytes make abnormal antibodies. Lymphocytes in CLL are not just a large number of normal cells. They make antibodies that are ineffective, so they don't fight infection. They make antibodies that are dangerous. They attack your own body, like hemolysis. Or they just don't make antibodies at all and you die of an infection. Lymphoma is the same thing because after all, CLL is a liquidy lymphoma, and the lymphoma is a solid CLL. In lupus, the lymphocytes also are either making antibodies that are not effective. They're not fighting that pneumococcus. The lymphocyte's supposed to be like a cop in the corner. Hey, fight that infection, fight that criminal, but it doesn't. Or what's worse, it attacks you, the normal person. Drugs such as penicillin, sulfa drugs, allopurinol, alpha-methyl-dopa is a drug we don't use at all anymore. It's safe in pregnancy, but we don't routinely use that as a blood pressure medication, but it does show up a lot as a cause of hemolysis on Step 2 USMLE exams. The most accurate test is Coombs test, which detects IgG on the surface of those red cells. And the direct and indirect tests basically tell you the same thing. The indirect is associated with greater amount of antibody because indirect basically means that there's so much antibody, there's some left circulating around in plasma that can adhere to new cells left in or thrown into the mix. But Coombs test is basically a test of seeing whether the cells agglutinate with IgGs on their surface. It's the most accurate test for autoimmune hemolysis with IgG, not the IgMs, but the IgG. Now remember, the autoantibodies can remove a small amount of the red cell membrane. They can make the membrane smaller, and it could force it to become round. Biconcave discs have a much greater surface area than a sphere. That's good, so it can take up carbon dioxide and get rid of oxygen. But autoimmune hemolysis is also associated with spherocytes as we force the cell into being somewhat smaller. The smear in autoimmune hemolysis will not show fragmented cells because the destruction occurs inside the spleen or the liver. It's not inside the blood vessel. It's extravascular, and extravascular means spleen and liver. The best initial therapy is steroids, glucocorticoids. And now, what happens if there's recurrences? You stop the steroids and it comes back, and you start the steroids again and it gets better. It stops the steroids and it comes back. You got to remove that spleen. Now, when the question describes somebody who gets a person with steroids and they continue to hemolyze, and you give them transfusion, you give them steroids, and they continue to hemolyze, severe acute hemolysis not responding to prednisone is controlled with intravenous immunoglobulins, and rituximab is sometimes used when splenectomy won't control the hemolysis. Rituximab gets rid of the lymphocytes that make the autoantibodies. Steroids in the long term can be deforming, so we need alternate treatments for that steroid. Cyclophosphamide calms down that immune system. Cyclosporin gets rid of those T cells. Azathioprine, 6-mercaptopirin, and mycophenolate mofetil all help control that immune system.